Hello, good night for everyone. You are very welcome to a new session on our YouTube channel. Tonight we will talk about blepharophimosis syndrome, which is a very common procedure, very common problem that we often see in our office, and this is a very important, but because it's not very well known for all the ophthalmologists, it's not very well known for some oculoplastic surgeons, and we want to show you how we deal with it and what is my thinking, my way of thinking on in such a problem. And first of all, let me put the slides. I can see it. Hold a second. I think it's coming. I'm really new on this technology. I'm not so skilled on doing that. I hope you can understand this technology things. This syndrome is very well known as a Marcus-Gunn syndrome or as jaw winking ptosis, and but one of the best definitions are those letters here. This Marcus-Gunn jaw winking synkinesis or syndrome. Synkinesis is the way of an aberrant innervation of one muscle, and this is Marcus-Gunn's jaw winking synkinesis. This is really slow. Okay, it was described first by Mr. Robert Marcus-Gunn in 1883. He was a Scottish ophthalmologist and is in the group of congenital cranial disinnervation disorders. So it's a disinnervation disorder itself. And it makes a synkinetic movement of the upper eyelid during the mastication movements of the jaw. This problem, the muscle that makes this connection is usually the external pterygoidal muscle of the jaw that moves the jaw laterally. Actually, there is a connection between the motor branches of the fifth nerve, cranial nerve, and the division of the third cranial nerve. I have to tell you that all the muscles of the eye that give movements of the eye are innervated by the third cranial nerve, and the pterygoidal muscles and the jaw muscles they used to do with the fifth muscle, the fifth cranial nerve. I'm sorry. And the most acceptable theory of Marcus-Gunn is the concept of aberrant connection. It's an aberrant, not normal connection of one nerve from this side to this side. So Marcus-Gunn is about 2 to 13% of ptosis problems. So all the ptosis, this is only about the 7%, more or less. It depends on the series, but it's really not common. It's mostly unilateral. It's more frequent on the left eye. As the congenital ptosis, we don't know why, but the congenital ptosis is more frequent in left eye than right eye. We don't know why. And bilateral is really strange, but I have seen last week one bilateral aberrancy of Marcus-Gunn. there is no gender predisposition, and Marcus Gunn is a phenomenon without ptosis in the 6.7% of cases. So about 5%, more than 5%, we can see the aberrancy of Marcus Gunn without the ptosis. And this is the people that we used to see Marcus Gunn, we often see Marcus Gunn without ptosis. Epidemiology is associated with strabismus. More than half of patients can have strabismus. Superior rectus palsy, 25%. Anisometropia, 25%. That means that there's a different graduation of one eye than the other, different refraction. So more myopia, more astigmatism, more hypermetropia in one eye than the other. So a big difference, 25%. And is related to 30 to 60% of amblyopia. Amblyopia is lazy eye. So this is one question that you do a lot. So can Marcus Gunn give a lazy eye? For sure, yes. Half of patients used to have amblyopia or lazy eye. Another systemic association with Marcus Gunn is cleft lip, cleft plate, and olfactory nerve disturbance. Charles syndrome. With Charles syndrome is a syndrome which have little things on the nose and on the ears, but some kind of heart problems, and is related sometimes with in some cases with Marcus Gunn, and renal calculi. There is a predisposed. The patient with Marcus Gunn can have arrhythmias, so it's wise, and we can do some electrocardiogram to those patients in order to detect some different arrhythmias, but it's not really common. The magnitude of the wink is worse in down gaze. So if you have winking or aberrancy and you look down, the superior lid show, sclera show, the white, when you see the white in the upper part of the globe, when you look down, is more visible. So looking down is much more visible. And the amount of aberration of the winking, we can measure in millimeters, and we can scale into a mild aberration with this 2 millimeters or less, to 5 as moderate, and more than 5 as severe aberration. Those are general things about Marcus Gunn jaw winking, and we are going to see some cases and some things, like in this patient here, like she's got in the upper part of the picture, you can see this little aberrancy. The aberrancy can slow down, so be less important with time. And when you are an adult, you can have a less aberrancy, a smaller aberrancy. But listen, what I can say is that in all those patients, even if it's a small amount of movement, aberrant movement, they want to remove, because they are always fighting against this and trying to avoid and hide this thing any moment on their lives. The picture down, looking down bilateral, when we did the bilateral, it's a symmetric thing when you look down. So this is one of the reasons why we are doing bilateral surgery, and we can remove the aberrancy of one eye, but we are doing bilateral correction of the ptosis or bilateral connection on the frontalis, as you can see in this patient just after the operation. I think the day after or something. Is very early in the post-op. Another case, here on the left, you can see another case that we have a mild ptosis, moderate ptosis, but we have if we with this video we can see exactly the same, but with a aberrancy a little bigger than the previous one. When she moves the move, it is a severe aberrancy. But we correct this lady with recess the muscle and then we connect both frontalis muscles to the eyelid in order to correct bilateral ptosis. And because the movements will be symmetrical, if we connect just the one, we do just unilateral. When they look down, there is a big asymmetry, and to have a best symmetry in general in congenital ptosis and also in Marcus-Gunn jaw winking, it's better to do it bilateral. You can see no movements. Have patience. She's a doctor in Russia, and she's a doctor, and she's so happy because we did bilateral. We have had some problems with some patients. We couldn't put some patients because we had some technical problems with some patients. This is the same patient here, and before and after, correcting the ptosis and correcting the aberrancy, and she has had twice a resection, muscle, an elevator muscle resection twice on the right. But elevator muscle resection is much more common to reoperate if we do, and to get a good result. Sometimes it's not that easy, and with frontalis flap we can achieve a very good height and contour, and it's better in my point of view. And just one shot we correct all the things. And as I tell you, we did bilateral in this case. Have another case here, in young lady. I'm sure you have seen this girl in my Instagram. She's from Portugal, and she had a severe aberration, and with a moderate to severe ptosis on the right. And if you can see the video, if the video run, like you can see here, there's a big movement. Just the day before the surgery, and we did the surgery just the day after. We passed through, and she did just the day after. No, the day of the surgery. So yeah, in the afternoon, we can see the difference. And listen, this is the day of the surgery, the day after the surgery, and okay, well, here we are. We can see the aberrancy is gone, and has the ptosis was corrected, and you can see the eye without ptosis, that it remains in position and it moves. When she moves, look down, she moves symmetrical, which is much better. And we also always say, we used to say that the best result is always with the best symmetry, and sometimes we have to do bilateral to achieve the best symmetry and to have the best result in unilateral ptosis. Okay, here we are. She's so happy. She was so happy the day after. Another case, this young boy, we did has a unilateral ptosis of the left with Marcus-Gunn of the left, and we also did the bilateral correction. You can see here. And we did the bilateral correction to have the best result possible. Okay, we can go. I think all those videos, you can see those videos on my Instagram, if you like. Sometimes we can do unilateral. This is one of the questions that that come to us. So, why to do bilateral or unilateral? It depends on a lot of reasons. But if you have a small boy like this, and we can do unilateral if we have time to recover. So one of the aims of our surgery in Ptosis, in any Ptosis, is to pass through the childhood happy children. And the bullying and the psychosocial problem comes at 4.5 to 5 years old. And if we have time to recover and recover the blinking and improve this condition, you can do unilateral if you like. But if you are older and the patients are older, we prefer to do it immediate, to have an immediate recovery in symmetry, and we prefer to do bilateral in adults or people from 6-7 years old that they suffer a lot. So, but I want to put this picture here because one of the things that happen with not only in Marcus Gunn, that happen with congenital ptosis is the amblyopia, and the amblyopia or the lazy eye. This is a good example that we did an correction of a ptosis on the right, and she came to us like this, and the mom says to us, "Oh, doctor, the eye is too low. I think you didn't succeed on the surgery," and the parents were not happy. And as soon as we correct the refraction, this is the position of the eyelid. So as soon as she put the glasses on, and this eye start to see, so the brain has to open it, and this is the position, and this is a very important thing to understand when you have a unilateral ptosis, in any case with Marcus Gunn or not. And this, when we do a frontalis flap, we do a very good connection on the frontalis with the eyelid, and if the brain asks to close one eye because it's disturbing the good vision of the other, so just putting down the brow, you look as an hypocorrected, as in this video here, that if it's running, you will see how a child can change so dramatically, so quick, just by fixating the vision on this. This is a video, and I hope it works. Look at that. She's completely good result, and she's completely good result with the glasses. We remove, and this is the condition. And actually, the eyelid goes down. We put the glasses on, and immediately the eyelid, the brain has to open to see for this eye. So this is a thing that used to happen in amblyopia eyes. You have a lot of questions about thinking that the result is not good. Am I always asking to correct the refraction if necessary, and to see how much does this eye, how much is the vision of this eye, because it's very, very important in order to have and to get a good result on this. Well, this is a short review of our treatments and of Marcus Gunn condition, and we are waiting for your questions here. And I'm happy to ask anything you can ask, or your doubts in here. We can have some question here. I did ask at the beginning. One of Rachel Fry. Is it possible or a good idea to have just a minimal resection of Marcus Gunn winking eye to cosmetically make it more equal, rather than doing the whole way, cutting the nerve? We are not cutting the nerve, cutting the muscle. and adjusting both eyes, doing better. So this is a very good question. So, or leaving the Marcus Gunn intact. So we can think. You have to think in two things. One is ptosis. We can correct it, and the other thing is the aberrance movement, and we have to separate. If you don't want to correct the aberrancy, that things that I don't recommend you. Why? Because this congenital ptosis is about psychological problems. It's about to avoid psychological problems, in my opinion, because it's the more devastating things that happen in children. So, and 100% of them used to have bullying and problems. If you have this aberrancy, you for sure will have bullying. And when some patients came to us when they are an adult and passed through all the childhood, all when they are teenagers, and they came to us and they can explain what happened on their lives. The story is always the same. It's about suffering, about depression, about introspection, about living away from the surgery, from the society, and don't take pictures and hide your problem. Even when the aberrant movement is tiny, probably people can see or can see it a little bit, but the patient feel it every moment, and this is a disadvantage of their lives, and this is a handicap in their lives. And they asked me to remove all of them. They remove this aberrant movement to feel more confident and to have more self-esteem, which is the most important thing, I think. And to correct this, the only way is to cut the muscle. You have to cut the muscle, and we provoke a severe ptosis that we correct with the frontalis muscle. So frontalis flap is a very good technique to correct severe ptosis, the best technique in my opinion. And this is why we are having such a good results in congenital in Marcus Gunn, because in Marcus Gunn we are inducing the most severe ptosis, which is the one that we cut the muscle, and we correct this, and then we have to think on ptosis. We cut the muscle and then think on ptosis, and the best is bilateral, because one of the things, if they feel that this little movement is affecting their lives, when you look down and you have a delay like this, and probably this will affect their lives. When there is a symmetry in the movements of looking down and up, the patients are really more happy. Another question: is congenital Marcus Gunn surgery irreversible? What's the worst case scenario? So I have seen some complications, not in myself, fortunately, but there were difficult situations. But is it irreversible? So if we cut the muscle, this is irreversible. The frontalis flap is reversible. We can redo it as many times as we like. We can undo it if we like. But when we cut the muscle, you provoke a ptosis, and this is really irreversible. But this is the only thing that is irreversible, because the frontalis we can go back and redo or undo if we like. And the worst scenario is that sometimes we've found that people that are not expert, when they cut the muscle, they cut two muscles, not one, and this is really dramatic. And because there are some the muscle, the rectus muscle, that the muscle that moves the eye up is very close to the elevator muscle, and I have seen some catastrophes on that, and not in my hands, but this is really dramatic. So this is to be done by a real expert. And what is the technique of the surgery to correct the aberrant movement? Well, there are several, but we have to cut the muscle. We don't know. There's a little nerve that we can't see, and from the one muscle here coming to the muscle that leaves the eyelid, and we can't see this little nerve, and the only way to be sure that this nerve is not acting is cutting the muscle, and we can cut it like this, or we have to, in some adults, we can cut the where this nerve is supposed to get to the levator muscle, which is the inner part of the levator muscle. So we can cut the inner horn of the muscle from to the bottom of the orbit, and we can be sure of that. And I only use this technique sometimes in patients that we can do this under local anesthesia, so in adults, because I want to be sure that the aberrancy is gone, and the only way to do it is under local. And when I'm very sure when I cut the muscle, this is gone, but when I do this technique by the medial horn release, I want to see it by with local anesthesia, that it's working. But this is the only way. No, we don't know any other way. I don't know, and I think this is the way, and works very well. I don't have any patient that we did we cut the muscle and we did like 60 cases last year, 60 in last 3 years, and we don't have any case that it came back or we didn't cut correctly the muscle. Next question. After the surgery, will both eyelids be blinking equally at the same time? Well, this I already answered. So blinking, when we do congenital ptosis and we do frontalis flap, when we are tying quite high the eyelid with very strong connection, we need a strong muscle to close, and it takes months to recover the strength enough to blink normally or naturally, and it takes some weeks more or months. Okay, but every week is better and better. And this is what I tell you: the more symmetrical result, the best result. The best in symmetry, the best result. So if you want to have good equal movements, do bilateral. The orbicularis muscle, it takes longer in the eye with the Marcus Gunn. Why? Because in any case that with congenital ptosis, when you have the eyelid down here and we have an eye here, the orbicularis muscle, the muscle that closes the eye, in this eye, the ptotic eye is really weak because no need to close, no need to have any effort to close. The other is very strong because it's blinking every day. So when we set the eyelid up, we need a strong muscle, and we don't have a strong muscle. We have a weak muscle, and it takes weeks to recover the strength to blink, and we need to use lubricants to avoid lack of thalamus and dryness on the eye. But it's very simple to manage. It's easy, and just to put some cream inside the eye, and we reduce every week in order to have a good quality of life. This is a very difficult question. So it's blinking is. You have patients that we did the operations in congenital ptosis for several years, unilateral cases, and the blinking is improving every year. So at the beginning, it's a big difference in the blinking. Second year is really difficult to see. When you have 5 years post-operative, the blinking is equal. So don't worry about that. But it takes time to recover. So let's do some questions about the order here. I'm very sorry. So some of you are asking to do it in Spanish, so it's so difficult for us to choose. And yo hablo mucho mejor en español. Desafortunadamente, la mayor parte de pacientes hablan en inglés y creo que deberíamos hacer otra sesión en español para entender. Espero que lo podáis entender y que por eso hacemos la sesión escrita para que pueda llegar un poquito mejor, pero es difícil hacerlo en los dos idiomas. Mi hija tiene Marcus Gunn y en un solo ojo, pero me he informado y que se suelen operar los dos. ¿Por qué? Ya hemos hablado. Se puede operar uno, pero el mejor resultado siempre es cuando operamos los dos. Hacemos un resultado. ¿Qué pasa? Que hay muchos cirujanos que no se sienten confiados en hacer cirugía de ptosis bilateral porque es muy difícil conseguir una simetría importante. Los expertos que nos dedicamos más a ptosis cada día, ptosis severa cada día, pues tenemos bastante mejores resultados en cirugía bilateral y es lo mejor para el paciente, de hecho. Bueno, yo creo que aquí hay muchos pacientes en español. Me sabe muy mal que toda la charla ha sido en inglés. You are planning to come to Russia? No, I'm not. So I'm allowed to operate in Spain. I'm allowed to operate in Peru. This is my place. It's about legal things. Is the surgery a permanent fix or it's temporary that it needs to be rectified after a few years? No, es una técnica, las técnicas que hablamos son técnicas que duran para toda la vida o hay que ir reoperando como pasa con los slings. Pues en principio es una técnica que dura muchos años. A veces hay que hacer pequeños retoques, a veces hay que tener pequeños retoques. Y en Marcus Gunn es un poquito más frecuente que en ptosis congénita simple. Y bueno, tenemos que reoperar un poquito más. Pero suele durar, intentamos hacer que dure toda la vida. So the question is about is it temporary or not? So my way of thinking is just do one shot, and for doing one shot and don't need to redo. What we do is we overcorrect the Marcus Gunn one because we know that Marcus Gunn the eyelid goes a little bit down, set a little bit down in the next months from the surgery. So we do bilateral, but do hyper correct the Marcus Gunn one, and then with time it sets and try to have a symmetric result that remains for years, and we don't need to redo. But sometimes we have to redo the frontalis flap in Marcus Gunn. Por favor, repite la charla en español. Si no, hoy otro día, os lo prometo, vamos a hacer una sesión en español muy parecida y con los resultados, con las preguntas en español. More questions. Hello, Dr. Ramón. My baby is 7 months now and the diagnosis of ptosis with Marcus Gunn. Just wanted to check what type of surgery is done to fix the issue. What is the appropriate age for surgery? So this is a very nice question. So Santosh. When is the best moment to do the surgery? Best moment, it depends. If, in my opinion, if the vision is affected, we have to do it as soon as possible. If we are sure that we have an amblyopia eye, so a lazy eye, we have to correct as soon as possible in order to stimulate the vision. So how to stimulate? So just setting the eyelid in position, putting glasses, using glasses if necessary, goggles, and patching the good eye in order to stimulate as much as possible this lazy eye. And when is the best moment? In my opinion, around the age of 1 year. We do the operations from 10 months. Why 10 months? Because ptosis is affecting the head position, and ptosis is more severe when children stand up and try to walk, and the age to walk is about 1 year old and around, and we want them to be to have the normal evolution. And when the children have a congenital ptosis and has a chin like this with 11 months, so there is a disbalance on the head, and there is a disbalance to walk, and they took more time to learn to walk because this is an affectation of vision. And this is why we do with the months. First, because we demonstrate that we had very good results at that age. We don't have the problems on anesthesia that if the children were younger, because the complications with anesthesia are worse with children less than 6 months, and so we are in a safe time, and we are helping them to have a good evolution and to start working as normal, a normal way. This is why we do the operations at that age. This is if we think there is a lazy eye. But if there is no lazy eye and we have only a problem of probably bullying at the school, bullying at the school starts at the age of 4.5 to 5 years old. So we have time to recover. And in my opinion, it has to be done before, in order to, when the kids gets this age, this dental that of age with problems, they has to be confident, and they has to forget about the ptosis, about the Marcus Gunn, about any problem, any asymmetry or any different thing with other kids. And this is why we recommend to do it if possible at the age of 2, 3, and better than at the age of 4, because at the age of 4 to 5 the problem has already has started, and we try to avoid that. Esta pregunta es muy importante, quizá la voy a contestar en español. A ver, Emma Esley, after ptosis surgery, can Marcus Gunn syndrome be developed in the next eye? No, forget about that. So this is a congenital alone problem, and it's really uncommon, and I don't think it is a possibility. So when we cut the muscle and we set the problem, usually we forget about that, forgot. So the only question, the last question was very important. So what is the best age? I want to answer in Spanish also. I'm sorry for English people now, but I already did in English. So en español, ¿cuál es la mejor edad para operar un Marcus Gunn? En mi opinión depende mucho si tiene una afectación de la visión o no tiene afectación de la visión. Si hay un posible ojo vago, tienes que hacerlo lo antes posible. y lo antes posible, en mi opinión, es a partir de los 10 meses. ¿Por qué? Porque es cuando se ponen de pie, cuando se van a poner de pie, y no queremos que vayan así porque no van a aprender a andar bien, porque les cuesta mucho por el peso de la cabeza y hay un desbalance para andar. ¿Vale? Con lo cual a los 10 empezamos a tener ya un buen resultado. ¿Por qué tan pronto? Porque tenemos que estimular el ojo vago. El ojo vago es un ojo que no se está desarrollando bien y tenemos que estimularlo para que llegue a una buena visión. Entonces, ¿cómo se estimula? Pues poniendo el párpado en su sitio, que se pueda pasar las imágenes a través de la pupila bien, poner gafas si es necesario y parchando el ojo sano para estimular la visión del ojo malo. Con lo cual, esa es la edad cuando hay afectación en Marcus Gunn y en cualquier ptosis congénita unilateral. Esa es la indicación. ¿Qué pasa si la visión es buena y no hay ningún ojo vago ni nada? Pues recomendamos evitar los problemas psicosociales que aparecen a los 4,5 o 5 años. Entonces, a los 4,5 o 5 años queremos que ese niño que se haya olvidado. Con lo cual, si operamos al niño al segundo año, tercer año, es lo correcto, en mi opinión. O al año, si se conviene con los padres, porque tenemos muy buenos resultados con cirugía precoz. Pero queremos quitarle la aberración y que los movimientos ya vayan un tiempo yendo juntos y recuperándose juntos los dos párpados, para que cuando llegue esa edad estén perfectos y se olviden de que hay un problema. Pueden tener pequeñas asimetrías, pero van a pasar desapercibidos durante la infancia y eso es justamente lo que queremos. Are there any complications with Marcus Gunn and winking later in life? En el futuro hay complicaciones. Entiendo, I understand that if we don't do the operations, it's just a psychological problem and probably a problem of unhappiness and a problem of sometimes depression on childhood and really not good quality of life in that terms. But any complication about that, any other complication, this is a big complication. If you do the surgery when you are a child, you forget about that for good. You forget. You can have, when you grow up, you can have little asymmetries because of the surgery that we can take very easy. Little retouches when they are are teenagers or when they are adults, and sometimes even nothing, because the result is really stable in time and we don't need to do anything else in life. So they forget, and this is the most important thing, in my opinion, is just to forget about your problem with little asymmetries like any one of us, but without a big problem with the ptosis or an aberrant movement. Maioria dos médicos falarán que não havia correção dessa condição. Well, actually, there is no solution for that. We cannot do like this and the problem has gone. No. So the thing what we are doing is to try to make the patient pass through life without any problem with it and without any affectation of the quality of life, which is the most important thing in life. And this is all about the surgery. So we are probably, when you have insufficient techniques for severe ptosis correction, like silicone sling, for example, is an insufficient, in my opinion, technique, you cannot offer this to a patient with a Marcus Gunn. So because it's not a good solution, and you are changing one problem, the Marcus Gunn, to another problem, which is the ptosis that has to be corrected 2, 3, 4 times during the next years. So this is not a solution. One of the things that frontalis flap is bringing us is a new engine a new way to correct in one shot. And this is why we can offer this to Marcus Gunn, and we are so happy because we forget about that. Because the result remained 4 years. We have patients that we did frontalis flap 18 years ago, and one surgery, unilateral, and they are perfect. So this is one of the good things of frontalis flap. This is why we can offer different things, because we have a technique that works a lot. And I did 800 frontalis flap at the moment. 800 is a lot, and we have so many results. I operate every week. Last week I did 12 in Malaga. The other week I operate 26 in Peru. I operate every day this, and the result is stable. So we can offer the patients a new thing that improve their quality of life one shot. And it's not. This is why some doctors that don't have all the solutions for ptosis can give you all the these results. And they used to say that this has no solution. There is no a solution for that. Quería contestarle en español esto también. O sea, ¿por qué? La pregunta anterior era ¿por qué muchos médicos dicen que no hay solución para Marcus Gunn? Porque la solución que tienen no es buena. El sling es una técnica que no da una solución fiable ni para el médico ni para el paciente, porque se tiene que operar muchas veces y da complicaciones. Con lo cual están cambiando un problema que es la aberración por un problema que es que una ptosis que le van a corregir y van a tener que operarse cada año o cada 2 años. Con lo cual no es una buena indicación. El flap frontal está aportando una cosa diferente, es que es una técnica que se mantiene en el tiempo durante años, con lo cual estamos dando una solución casi definitiva y estamos quitando el problema y dando una solución casi definitiva. Es por eso que vamos a escribir nuestra experiencia en Marcus Gunn y en otros síndromes con el flap frontal, porque es, en mi opinión, la mejor técnica con mucha diferencia para ptosis congénita, incluida Marcus Gunn. A ver, había más preguntas por aquí. Prometo hacer una sesión en español. How do you measure if the surgery is worth doing when the patient has a minor Marcus Gunn syndrome? Very good question, Kasia. Very good question. The question is, if you have a ptosis with a little Marcus Gunn, not a big Marcus Gunn, a little Marcus Gunn, it's about discussing with the patient. But I did a lot of minor Marcus Gunn in adult patients that the only thing that they want on their lives is to remove this tiny movement, because it's about self-esteem. Is what I tell you. It's about happiness and self-confident. To be self-confident, and the patients, I don't know if 100%, but the majority of adults that talk to me, they say, I didn't want to have this. I don't want to have this. I want to, even if you have to do a big surgery or just cut the muscle, provoke a severe ptosis and correction with the frontalis flap, if there's a possibility to remove, they ask to remove. So this is my opinion, with years doing that and 1,000 patients with congenital ptosis and Marcus Gunn on my office. So this is why I recommend to do this. But you have to discuss with the patient, and if you want to live with this, okay, you can correct the ptosis. But correcting the ptosis, you have another problem, because when you have a ptosis and a mild movement, the cornea is always blocked by the eyelid. When we correct the ptosis and you have the movement, you have a upper superior scleral show, the white thing over the cornea here, that is really nobody likes that. This is really horrible, and so it's more noticeable the aberrancy than before. So it's like to do a thing in half and to obtain nothing, because what you get is even worse. When you have, well, you are like this, but in any moment you have the cornea like this and the scleral show like this, and I don't like that. And we have some good results by doing what we are doing, that I'm so happy. I can recommend another thing. So la pregunta es muy fácil, es ¿por qué ¿cómo medimos? Si tienes una pequeña aberración y una ptosis, ¿por qué no corregir la ptosis y dejar la aberración pequeña? Eso lo hacíamos, yo lo hacía muy al principio porque yo no tenía una solución buena para la ptosis. Hace 20 años que tenemos una solución muy buena para las ptosis severas. Con lo cual, no nos da miedo tener una ptosis severa, porque la solución que tenemos es muy buena. Y lo que hacemos, imaginaos que ponemos el párpado en su sitio y tiene movimiento. Se va a ver lo blanco por encima de la córnea, que se llama scleral show superior, que es muy indeseable, es muy poco agradable, es peor. Con lo cual, porque se hace mucho más evidente el problema. Y realmente yo creo que no es la solución. Bueno, muchas preguntas aquí. I tried not to repeat the questions. Does Marcus-Gunn syndrome get worse with age, or perhaps it may get better, or it's always the same? Very good question, Paui. So the aberrancy, the aberrant movement, with age is improving. So the movement is smaller with the age, and this is the normal evolution. And but it remains for good probably, and it's not equal, it's not worse, it's probably a little bit better, but it remains for good. La pregunta es si el síndrome empeora o es igual o mejora con el tiempo, y lo que le he contestado es que sí que mejora. El movimiento cada vez es más pequeñito, o sea, de una forma muy sutil. Hay movimiento que es de 8 milímetros cuando naces, y cuando tienes 15 años es de 5 milímetros, que es mucho, y cuando tienes 30 años es de 4 milímetros o 3 milímetros y medio, que sigue siendo visible, pero es mucho menor, ¿no? Con lo cual el movimiento aberrante mejora con el tiempo. Pero eso no quiere decir que no tenemos que quitarlo, porque el movimiento aberrante se va a mantener para siempre, seguramente. ¿Cuál es la edad propicia para operar? Ya hemos hablado de eso. ¿Hasta qué edad se puede operar? Tengo un niño de 4 años. En mi opinión, Jocelyn, 4 años es un límite ya casi tarde para mí, porque lo operamos mientras se recupera la inflamación y recupera tal, ya estamos en los 5, y ahí es cuando empiezan los problemas. Justo es, como he comentado antes, intentamos hacerlo antes para que cuando llegue esa edad, que es una edad problemática para el bullying y para los problemas psicosociales, que son los 4,5 para 5, ahí se haya pasado todo ya. Y que si ha evolucionado un año ya parpadeando tal y simétrico, y ya ni se acordará. Si lo operamos a los 5, va a estar muy bien, va a pasar la inflamación y sí, el parpadeo va a tardar un poquito más en ser simétrico. Pero luego, nosotros intentamos que no le afecte. Y para que no le afecte, que esté solucionado completamente antes de los 4,5. Esa es mi forma de pensar. Bueno, no sé. ¿Qué hora es ya? Ya casi tenemos 1 hora. ¿Alguna pregunta más? Por aquí hay muchas, ¿eh? Powell. Does Marcus-Gunn syndrome causes some kind of asymmetry regarding motoric development? Or babies physiostate it influences asymmetry of the body and our movement. Is that true? So the thing is that, Paul, if you have a ptosis, your kids will live like this. And some patients complains about torticollis, about the neck position. And when we set the ptosis, the kid do like this. And say, wow, the neck problem disappeared because he hasn't any neck problem. So the problem is the ptosis. Ptosis creates a position to see better, and the brain has to see better and looks for the position. Even as with the strabismus, it has a squint, so the brain used to look for the position to see good, and it creates a torticollis, which is an abnormal position of the neck and the head. But if you correct it and you have the good ideas, the good images in front, so the neck puts in position immediately because it's the brain asking to see, and this is the all about. So then the neck position is related to the ptosis, not to the Marcus-Gunn, to the ptosis, to any ptosis, and we have to correct it because, as I tell you, when they try to start to walk, and if you have your neck like this, you have a disbalance. They go back with the head of the weight of the head. So, and we want them to be like this and to start walking like all other kids, and it's normal. Okay. La tortícolis es muy importante. La tortícolis normalmente el 90, en casi todos los casos, algún caso habrá que haya una tortícolis asociada, un problema asociado, pero la tortícolis es secundaria a la ptosis. La ptosis es la que produce que tú tengas la posición de la cabeza diferente para ver mejor. Y en cuanto corriges la ptosis, el niño pone la cabeza recta y se olvida. Por eso es tan importante operarlos antes de que empiecen a andar, que es cuando realmente tienen que tener una buena posición y no se desequilibran con la cabeza para atrás para andar. Y empiezan a andar más tarde porque no tienen buen equilibrio por el peso de la cabeza para atrás. Bueno, chicos, yo creo que ya llevamos 1 hora aquí. Yo creo que, yo no sé, yo creo que deberíamos repetir. Me ha encantado, hay un montón de preguntas aquí interesantes. Pero yo creo que es un tema que podemos repetir, más basado en castellano, si queréis, porque he visto que muchos de vosotros me lo habéis pedido. Y os prometo que haremos alguna sesión de más en castellano, tanto de blepharofimosis, de Marcus-Gunn y de ptosis congénita, si queréis. So I think we have done a lot of questions here, and I hope you have a better idea of what is Marcus-Gunn and what are the how to correct it and why we do this. But there are still a lot of questions here, and I try to do another session to ask more questions, and also in Spanish. I see a lot of Spanish people here that or English is really not good, and I try to do it again. I hope you have a better idea of what Marcus-Gunn is, and a better idea of my way of thinking to treat Marcus-Gunn and to have in order to get good results. And actually we have done more than 60 in last I'm operating every day, and I'm learning every day. I'm improving every day the techniques, and in order to do the best for children and the small number of surgeries for them, because any surgery in a kid is a disaster. I don't like to my son or my daughter to undergo any surgery, and if I have to do it, I prefer to do it in one shot, because if not, it's a suffering for everyone, for the kid, a suffering for the parents, a suffering for the surgeon, and this technique, frontalis flap, is helping a lot to get shorten the number of procedures and to have in one shot good result for a lot of years. I hope you enjoy, and don't hesitate to keep giving us your opinion or your recommendations about the next live session or about this session, and please tell me what you think about, because I'm learning on this media, and but I'm so happy because I think a lot of people is here and a lot of questions come to us, and people is wanted to know at least my opinion. I'm really glad and happy and an honor to have you here. So thank you very much. I hope to see you in the next session. Thank you. Bye bye.